Assalamu alaikum everyone. I hope you're all doing great. My name is Walid Nassar. I'm a fourth year medical student, and today I'll be giving a talk on the muscles of the forearm. Now, just as a quick run through the contents of the lecture, I'll be discussing the bones and bone markings. I'll be discussing the flexor and the extensor regions of the forearm. I have some clinically related scenarios, and at the end, I'll have a couple of practice questions. Now, just to orient you guys are probably familiar with this slide by now. So this is the osteology of the forearm. Now, what does osteology mean? It's just different bone landmarks or different bone prominences that are named for anatomical purposes, or for different muscle attachments. Now, it's really simple. It looks really crowded, but it's actually really easy to memorize. Like most of the stuff are actually duplicated on the other side right here. This could all be done in like 5 minutes or 10 minutes max. A way I used to memorize it, back in the day, I did not have Anki, or I did not know what Anki was, so I just used to cover the different names by blank boxes, sorry. But there are important stuff that you guys need to know before we move on to the lecture. So the upper arm bone, as you guys know, is the humerus, and the forearm bones, we have two bones. We have the ulna and we have the radius. Now, the ulna is the medial bone and the radius is the lateral bone. So there's another important thing on the humerus. So at the base of the humerus, or on the inferior side of the humerus, we have two different prominences. We have the medial epicondyle and we have the lateral epicondyle. Now, why is this important? This is a really important landmark because most of the flexors in the forearm actually arise from the medial epicondyle, while most of the extensors of the forearm arise from the lateral epicondyle. Now, if the epicondyle gets inflamed, you just add the suffix, or to anything in general. If something is inflamed, we add the suffix itis to the end of the word. So if we add itis to the end of epicondyle, it will be called epicondylitis. So when the medial epicondyle gets inflamed, it's called medial epicondylitis. If the lateral epicondyle gets inflamed, it's called lateral epicondylitis. Now, moving on to the carpals and your phalanges. So this is actually really important, especially for your OSPE. The doctor could just simply get you guys an X-ray of the wrist, and he would just ask you guys to, he's going to point out one of the bones, and he's going to ask you guys to name one of the bones of your carpals. So you have 8 carpal bones, you have 5 metacarpals, you have 5 proximal phalanges, 4 intermediate phalanges, and you have 5 distal phalanges. Now, you have 4 intermediate phalanges, hence why the thumb is the shortest out of all the fingers, because it's missing an intermediate phalange. The thumb only has a proximal and a distal phalange. So the different names of the carpal bones are the scaphoid, the lunate, the triquetrum, pisiform, hamate, capitate, trapezoid, and trapezium. Now, a mnemonic that I used back in the day was straight line to pinky. Here comes the thumb. So straight scaphoid, L lunate, T triquetrum, P pisiform, H hamate, C capitate, T trapezoid, and the last T would be trapezium. So I want you guys to look at these colorful boxes, and I want you guys to think of them as your carpal bones. So straight line to pinky, you guys make a U-turn, but then here comes the thumb. So again, straight line to pinky, scaphoid, lunate, triquetrum, and pisiform. Here comes the thumb, hamate, capitate, trapezoid, and trapezium. Now, it looks that the pisiform is actually like before the triquetrum, while it's actually not. It's just like an illusion because the pisiform actually sits on top of the triquetrum. It's not before the triquetrum. So now these 2 points are really important. I've run through your slides. I don't think it's mentioned. I think it's going to be mentioned in your hand lecture. But just to be sure, I mentioned them here since we're discussing the carpal bones. Now, the most commonly fractured bone, or the most commonly fractured carpal bone, is your scaphoid bone, and the most commonly dislocated carpal bone would be your lunate bone. So the scaphoid right here is the most commonly fractured, and lunate right here is the most commonly dislocated carpal bone. Now, moving on to the layers of the forearm. So again, to orient you guys, we have an anterior, posterior, a medial, and a lateral side. So firstly, and most obviously, we have the skin layer. Once we're past the skin layer, we have the superficial fascia or the subcutaneous fascia. Now, sub meaning under, cutaneous meaning skin. So it basically means fascia that's under the skin. Now, since we have the superficial fascia, we also have a deep fascia. I'll be discussing that after the slide. So before moving on to the deep fascia, we have two veins that are embedded in the superficial fascia. We have the basilic vein and we have the cephalic vein. Now, it's really important to differentiate between which vein is on which side and even the names of the veins. So a way I used to memorize this is basilic or base, or basilic is close to the word base. So base meaning the base of the body or the medial side of the body. So خلاص, basilic, medial side, and B, the letter that comes after the letter that comes after B would be C, so cephalic vein. So basilic near the base of the body. After B comes the letter C. Cephalic vein is on the lateral side. Now, as I said, we have a superficial layer. We also have, or superficial fascia. We also have a deep fascia. Now, the deep fascia, it has a similar function as a superficial fascia, although it's more deep. It closely houses the muscles, preventing them from moving anywhere. Now, we've already discussed this. You have two bones in your forearm. You have the medial bone, which is the ulna, and you have the lateral bone, which is the radius. Now, there's like a small partition, differentiating between the two compartments of the forearm. You have the anterior compartment and you have the posterior compartment, and the partition is actually called intramuscular septum. Now, from its name, intra, in between, muscular, so in between muscles, septum. So septum in between muscles. As I mentioned, divides the anterior and the posterior compartment of the forearm. Now, in between the radius and the ulna, we have a dense connective tissue holding the radius and the ulna closely together, as well as serving protection. Now, it's also a really important anatomical landmark because some of the arteries are named depending on the relation to the interosseous membrane. I'll emphasize on this later as well. Now, there are some primary functions for the anterior compartment muscles. So there are three main functions. There's flexing the wrist, there's flexing the digits, and pronation of the forearm. Now, there are three main nerves in your forearm that are responsible for both sensation and muscular contraction or motor function. You have the ulnar nerve, the medial nerve, and the radial nerve. Now, the ulnar nerve is on the medial side. The medial nerve would be on the lateral side, and the radial nerve fully supplies the posterior compartment of the forearm. Now, our main focus for now, or this part of the lecture, is the ulnar nerve and the medial nerve. Now, this is a general rule for all muscles, both in the anterior and the posterior compartment. Muscles are usually named depending on, like, this is actually chronological. So the action done on, location of the muscle, and the feature of the muscle. So what do I mean by this? So let's take an example. So this is one of the muscles in your extensor compartment or your posterior compartment of the forearm. It's called extensor carpi radialis brevis. So action, this muscle extends, so it's called extensor. Action done on, this muscle extends your carpal bones, so it's called carpi. The location of the muscle sits on the radius or the radius bone. Hence why it's called radialis. And the feature of the muscle, brevis. Brevis just means short. So anything like a feature or a property of a muscle, it's usually at the end. Now, this isn't always true. Sometimes muscles are only named based on 1 and 2. It does not have 3 and 4. But usually all muscles have 1 and 2. The function of the muscle or the action and the action done on. Okay, now starting with the actual lecture. So in the anterior compartment, you have even more compartments. You have a superficial layer or three different layers. You have a superficial layer, you have an intermediate layer, and you have a deep layer. Now, starting with the superficial layer, you have 4 muscles in the superficial layer. Now, remember when we discussed at the base of the humerus, we have something called, or known as the medial epicondyle. So this is also called the common flexor origin. So common flexor origin, most of the flexors of the forearm arise from this point right here. Now, 4 muscles in the superficial layer. We have the pronator teres, we have the flexor carpi ulnaris, we have the palmaris longus, and we have the flexor carpi radialis. Now, starting with the pronator teres. So pronator, we said the function of the muscles first. So it pronates, and pronation is, as you guys can see, the movement pronation is right here. The function is pronation of the forearm at the proximal radial ulnar joint. Now, why am I saying proximal radial ulnar joint? Proximal meaning this side, basically. So this is the radial ulnar joint, and this would be the distal radial ulnar joint, because there's another muscle actually that also pronates, that sits at the distal radial ulnar joint. So for now, the pronator teres functions primarily to pronate at the proximal radial ulnar joint. It's innervated by the median nerve. So there's a special feature about the pronator teres. Now, so this guy's a pro, it's like a pro boxer. It has two heads, tamam? So there's a humeral and an ulnar head. Now, what's really important about this fact is that the median nerve actually passes through the two heads. Now, if a muscle hypercontracts or hypertrophies or gets inflamed or anything wrong with the muscle or anything that goes wrong with the muscle, the median nerve actually gets impinged and results in a syndrome known as pronator syndrome, which is basically that the nerves become weak and the muscles that are going to get supplied by that nerve even get weaker, or you could actually lose complete function. Now, your second muscle is the flexor carpi radialis. So again, from the name, flexor, it flexes, carpi, the carpals, and radialis, it sits on the radial bone. So the function is flexion of the wrist and wrist abduction. The innervation is on the muscle gets innervation from the median nerve. So you guys can see this here, right? This right here is the flexor carpi radialis. Now, it says it abducts the wrist. Now, since it's on the lateral side of your wrist, it only makes sense that if this muscle shortens or contracts, the wrist will go this way, which is basically abduction. And it's also attached to the phalanges or to your carpal bones right here. So it only makes sense that if this muscle also contracts, it will bring upon flexion on your wrist. Now, the next muscle is your palmaris longus. So this muscle is actually the only muscle that has an aponeurosis. So this right here is the aponeurosis. So what is an aponeurosis? It's basically like a connective tissue that's attached to your skin. So the palmaris longus, so palmaris meaning palm, and longus meaning just a long muscle. The function is to tense the palmar aponeurosis. The blue part, I've actually missed putting a blue part here, but no, just so you guys know, this is the aponeurosis. So it's a flat fibrous band of tissue located in the palm of the hand. And again, it's innervated by the median nerve. So you guys are actually try to catch upon the pattern of the median nerve. So far, we discussed 3 muscles, and all of them are supplied by the median nerve. Now, a special feature about the palmaris longus, other than it has an aponeurosis, it's actually absent in a significant percentage of the population. So a lot of people don't actually have the palmaris longus itself. Now, then we have the flexor carpi ulnaris. So again, flexor, flexing, the carpals, ulnaris is on the ulnar side. So it's similar to the flexor carpi radialis, although it's on the ulnar side. And there's another difference in the function. So if you guys remember, the flexor carpi radialis, it flexes the wrist, although it abducts, while the ulnaris, since it's on the medial side of your arm, it's gonna adduct. Tamam? So the radialis would be on this side, would bring upon abduction, and the ulnaris would bring upon adduction. Now, so this is the special feature right here. It's innervated by the ulnar nerve, which really makes sense since it's named ulnaris. Also, it's on the ulnar side of the bone, so it would make sense that the ulnar nerve supplies this muscle. Now, it actually has 2 attachment sites. It's attached to the pisiform, so the carpal bone that we just discussed, and the base of the 5th metacarpal. So your pinky is actually on your medial side, so it will make sense that a bone on the ulnar side would be attached to your pisiform, which is the 1st carpal bone on your ulnar side, and the base of the 5th metacarpal, which is also on the ulnar side. So it all conveniently makes sense. Similar to the pronator teres, there's also a special feature right here, the entrapment syndrome. Basically, the ulnar nerve gets impinged here if the muscle hypercontracts or there's anything wrong with the muscle. It can bring upon weakness to the ulnar nerve, or even permanently damage it. So this is a mnemonic I use to memorize the superficial anterior compartment of the forearm. So piff puff. So I just remembered like a mosquito biting someone's forearm right here, and you're using some piff puff to spray it off. So P would be for pronator teres. Just remove the I and the A in piff puff. So pronator teres, flexor carpi radialis, palmaris longus, and the flexor carpi ulnaris. Now for the blood supply of your forearm. Now you guys know from the brachial plexus lecture, you have the brachial artery. Now the brachial artery divides into two main branches: the radial artery, and your ulnar artery. Now you guys can also see that there are different arteries right here called the interosseous artery, anterior interosseous artery, and the posterior interosseous artery. So you guys remember that thick, dense tissue that sat between the radius and the ulna? I told you guys that it's an important anatomical landmark. So this is specifically why people use it. So anterior interosseous artery, meaning anterior to the interosseous membrane, and the posterior interosseous artery, meaning posterior to the interosseous membrane. Now moving on to the intermediate layer, we have only one muscle right here. It's called the flexor digitorum superficialis. So flexor, it flexes. Digitorum, digitorum just means digits, so you're basically your fingers. And superficialis meaning it's on the superficial layer. Now, don't get this mixed up. We actually have another muscle called the flexor digitorum profundus, or it's like the deeper flexor digitorum. When we're saying superficialis here, we don't mean that it's in the superficial layer. It's in the intermediate layer, although it's superficial in comparison to the flexor digitorum profundus. So this right here is the visual representation of the flexor digitorum superficialis. The function from its name, it flexes the digits. So it flexes upon the proximal interphalangeal joint, and it also flexes your wrist. Now, it flexes only 4 out of your 5 fingers. It does not flex your thumb. We actually have another muscle that flexes the thumb. But for now, the flexor digitorum superficialis only functions to bring upon flexion for the 4 fingers of your hand. So this muscle is actually innervated by the median nerve. So far we've discussed 5 different muscles. We discussed the pronator teres. We discussed the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris, and the flexor digitorum superficialis. Now all of them are innervated by the median nerve except for one muscle, which is supplied by the ulnar nerve, which from its name, the flexor carpi ulnaris. So far everything seems easy. Now, a way I used to memorize the intermediate layer is the rule of 5, actually. So I just remembered that intermediate. So I took the I as the Roman numbering. So I used the I as the Roman numbering way. So I counted 5. So 1 would be indicating that there's only one muscle in the compartment. 2, meaning either there's 2 heads, the humeral ulnar and the radial. And it also sits between 2 bones, the radius and the ulna. So from the picture here, you guys can see it sits between the radius and the ulna. And it has 2 heads, the humeral ulnar and the radial head right here. Now 3, I just flipped the 3 and made it as like it looked like an M for me, indicating it's supplied by the median nerve. And 4, it supplies 4 nerves, or it brings function to 4 fingers. Sorry. And 5, I just remember the 5 as an S, so it's the superficial muscle, not the deep muscle. So moving on to the deep layer. Now, before moving on to the deep layer, as a general rule, even for the rest of the lecture, if we move on to a new compartment, we usually change the nerve. Now, we did not do that here for the intermediate and superficial layer because the intermediate layer is actually also part of the superficial layer, but just for detail purposes, people divided them into superficial, intermediate, and deep layer. So the deep layer actually has another nerve arising in that layer, what's called the anterior interosseous nerve. Now, the anterior interosseous nerve is just a branch of the median nerve, but it's only specific to the deep layer of the forearm. Now, remember the pronator teres? We said it primarily functions to pronate onto your proximal radial ulnar joint. So this is the opposing guy, or this is the guy that sits at the end. So this is the pronator quadratus. Now, pronator, again, it pronates. Quadratus, it just means like a quad-shaped or square shape. So it is actually square shape and does pronate. So he sits at the distal radial ulnar joint. It's innervated by the anterior interosseous nerve, which is, again, the branch of the median nerve. So again, works in coordination with the pronator teres to ensure fine pronation. Now, the second muscle in the deep layer is your flexor digitorum profundus. So we took the flexor digitorum superficialis. This is the one I was talking about, the other muscle, the flexor digitorum profundus. Profundus just means deep. So a muscle that flexes your digits and the deep layer. Again, the function primarily flexes the distal interphalangeal joint of the fingers. It also assists in inducing flexion on the PIP joint and the wrist joint. Now, any muscle that crosses a joint induces flexion upon that. So you guys see the flexor digitorum profundus goes all the way to your distal phalange. Okay, every joint before your attachment site could possibly be induced upon the muscle for flexion. For flexion to be induced upon. يعني this muscle right here attached to the distal phalange induces flexion on your proximal interphalangeal joint. It induces flexion on your wrist joint as well. And of course, its main function, which is inducing flexion on the distal interphalangeal joint. Now, profundus, it actually has a really important and high-yield feature. It's innervated by two nerves. It's innervated by the ulnar nerve, and it's innervated by the anterior interosseous nerve. Now, anything that's innervated by the ulnar nerve, it will only make sense that it will only take part on the medial side, and anything that's innervated by the anterior interosseous nerve would be on the lateral side. Okay? So the pinky and the ring finger, right here, is innervated by the ulnar nerve, and the movement is innervated by the ulnar nerve, and your index and middle finger is innervated by the anterior interosseous nerve. Now, a way I used to memorize this is profundus. So I took the last like this, and I made it sound like deuce. So deuce meaning two. So it's innervated by two different nerves. So it's really important to know that which fingers are innervated by which nerve. So pinky, ring finger, ulnar nerve, index and middle finger, anterior interosseous nerve. Now, flexor pollicis longus. Now, flexor meaning flexing. Pollicis does not actually mean a policeman. It actually means a thumb. And longus means the long muscle. Now, function primarily flexes the thumb at the interphalangeal joint, which means it bends the thumb inward towards the palm of the hand. It also assists in flexing the thumb at the carpal-metacarpal joint. Now, this here, right here, is opposition, and this right here is flexion. So two main functions, opposition and flexion. Again, innervated by the anterior interosseous nerve. Now, just as a recap and an important table to differentiate between the FDS and the FTP, so the flexor digitorum superficialis and the flexor digitorum profundus. The location of the flexor digitorum superficialis is in the intermediate layer. Remember the rule of fives. The location of the flexor digitorum profundus is in the deep layer. The innervation of the FDS is the median nerve. The innervation for the FTP is the anterior interosseous nerve. The attachment is the middle phalanx for the FDS, while the FTP is the distal phalanx, which actually really makes sense. Like, since this is on the superficial layer, it wouldn't reach as much length as the deep one. So the FDS is just superficial, only reaches the middle phalanx, as you guys can see right here. Only reaches the middle phalanx, does not reach the distal phalanx, while the FTP does reach the distal phalanx, which is why it brings upon flexion on the DIP joints. Again, so function induces PIP joint flexion and wrist flexion, no DIP flexion. And here it induces DIP joint flexion, PIP joint flexion, and wrist flexion. Remember the rule that if the muscle fibers cross a specific joint, خلاص, it must induce or it must aid in inducing flexion or the action to that specific joint. Okay, so we're officially done with the anterior compartment. Let's move on to the posterior compartment. So in the posterior compartment, we only have two different layers. We have the superficial and we have the deep. So again, just as a recap, we said that the ulnar nerve, we have two nerves in the anterior compartment, the ulnar nerve and the median nerve. And in the posterior compartment, we have the radial nerve. The radial nerve is the main guy that supplies the extensor compartment of the forearm, or the posterior compartment. Now, the muscles in the posterior compartment function primarily to wrist extend, finger extend, thumb extend, and adduction and abduction of the wrist. Now, similar to what we did in the anterior compartment, the posterior compartment actually changes nerves as we're moving on to the different compartments. So for the superficial layer, we have a branch of the radial nerve known as the posterior interosseous nerve. So it's posterior to the interosseous membrane. Now we discussed one of the anterior interosseous nerve, which was the branch of the median nerve, which was in the anterior compartment of the forearm. Now we're discussing the posterior interosseous nerve, which is posterior to the interosseous membrane, and it supplies the superficial extensor compartment of the forearm. Now, again, similar to the flexor compartment, superficial layer, we have a common extensor origin, which is on the lateral epicondyle. So if you guys remember, the common flexor origin was on the medial epicondyle, while the common extensor origin is for the extensors in the posterior compartment of the forearm. Now we have 6 muscles in the superficial layer. So this right here is just to show the common extensor origin. Now the 6 muscles, we'll start going through them right now. We have firstly the brachioradialis. Now, just before moving on to the brachioradialis, this guy has a really special feature. He's actually really weird. He's part of the extensor compartment, although it flexes the forearm. So it's the only muscle that does not have the word extensor in it. As we move on, you guys will come to notice that. Now it's actually really visible right here. So it's actually called the handshaking muscle. So whenever you shake someone's hand, you're in mid-prone position. So you're not in full supination and you're not in full pronation. You're mid-prone, so you're somewhere in between. So similar to someone shaking someone else's hand. So it's really prominent here on this muscular guy. So this right here would be the brachioradialis. So brachial, meaning on the arm. Radialis means radius. So this guy attaches to the brachial and the radius. Now again, function, flexion of the forearm and rotation of the forearm to mid-prone position. So it's really important to know which muscle induces the mid-prone position. Now, the innervation is the posterior interosseous nerve, which is again the branch of the radial nerve. So it's visible right here. Now, it's really important to also notice that the brachioradialis does not arise from the common extensor origin. So it's the only muscle that does not arise from the common extensor origin. All the different muscles of the superficial posterior compartment of the forearm arise from the common extensor origin, except the brachioradialis. Okay? Okay, so the next muscle is the extensor carpi radialis longus. So extensor, meaning it extends. Also, you guys are pro at this by now. Extensor, meaning it extends. Carpi, the carpals. Radialis, it's on the radius bone. Longus, meaning just long. So it's a long muscle. Function, from its name, extension and abduction of the hand. If you guys actually memorize the names of each muscle, يعني the function of the muscle class just comes automatically. And it's really that simple. The innervation, again, similar to the brachioradialis, the posterior interosseous nerve. The next muscle is the extensor carpi radialis brevis. So it's literally the same as the longus, but it's shorter. So it's the same muscle, it has the same function, it extends, it abducts, although this one is shorter than this one. This one seems longer, this one seems shorter. So it's just a basis of differentiating between the properties of different muscles. So خلاص, same function, almost same name, they must have the same nerve as well. So which of the following forearm muscles highlights the extensor carpi radialis? I'm gonna give you guys this like 10 seconds. Okay, so the answer here would be B. So this one obviously seems like the longer muscle, which is why it's the extensor carpi radialis, longest. The next muscle is the extensor digitorum. So the extensor digitorum, from its name, it extends the digits. It's innervated by the posterior interosseous nerve. So there's nothing special here. So we're all following the similar. They're all following the same pattern. They're giving function based on their names. We're still in the same compartment, so we're still using the posterior interosseous nerve. I think we have two muscles of yes. We have the sorry. Okay, we have the extensor digiti minimi. So digiti minimi, digiti means digit, minimi means small. So your pinky is actually like the tiny finger in your hand. So extensor digiti minimi, so you're extending the pinky. So function again, extension of the MCP joint of the pinky. Now it's innervated again by the posterior interosseous nerve. So you guys see the pattern here. Now we have the extensor carpi ulnaris. It extends the carpals, although it's on the ulnar side. So it extends and adducts the wrist. So let me just go back here. We have the extensor carpi radialis brevis, and we have the extensor carpi ulnaris. So there's one on the ulnar side and there's one on the radial side. And it's innervated by the interosseous nerve, posterior interosseous nerve. So we discussed 6 muscles. We said that the brachioradialis is the only muscle that did not arise from the common extensor origin. The common extensor origin is basically on the lateral epicondyle. The brachioradialis is really important for the mid-prone position. It does not extend. It's in the extensor compartment, although it does not extend. It flexes the forearm. Extensor carpi radialis longus, interosseous nerve. Extensor carpi radialis brevis, interosseous nerve. Extensor digitorum, interosseous nerve. So all of the muscles of the posterior compartment in the superficial layer are innervated by the posterior interosseous nerve. Well, now we're in the deep layer. خلاص, we go back to the rule. We have a new nerve innervating this compartment or this layer. So we have another branch of the radial nerve known as the deep branch of the radial nerve. So like unlike the anterior compartment of the forearm where we had 2 different nerves, the ulnar, the median, here it's all completely by the radial branches of the radial nerve in the posterior compartment. It's just different branches of the radial nerve. So we had the posterior interosseous nerve. Now we have the deep branch of the radial nerve, which is really convenient since we're in the deep layer. It's the deep branch of the radial nerve. Now, firstly, we have the supinator muscle. So from its name, this is really simple. It's getting really simple. So supinator, it sits right here, and it functions to supinate. Innervation, just like we discussed, deep branch of the radial nerve. Now, a special feature of the supinator muscle is entrapment syndrome, although the nerve that is affected is the radial nerve, which makes sense since the supinator muscle sits in the posterior compartment and is innervated by the deep branch of the radial nerve. So it makes sense that if anything wrong happens to the muscle, the nerve supplying that muscle would get affected. The next muscle is the abductor pollicis longus. Sorry. The abductor pollicis longus abducts, pollicis meaning thumb, longus meaning it's a long muscle. So it functions to abduct and extend the thumb. The nerve is the deep branch of the radial nerve. But then we have the extensor pollicis brevis. So the extensor pollicis brevis extends the thumb at the MCP joint. So the metacarpophalangeal joint, the joint between the metacarpals and your phalanges. تمام. Now it's innervated by the deep branch of the radial nerve as well. All the muscles in the deep layer are innervated by the deep branch of the radial nerve, sorry. Then we have the extensor pollicis longus, which is it's similar to the extensor pollicis longus. I'm sorry, it's similar to the extensor pollicis brevis, although it's longer, so it makes sense. If it's longer, it's going to attach to the more distal joint. So you guys can see here, it's attached to the more proximal joint, since it's brevis, it's the shorter muscle. The longest is a longer muscle, so it makes sense. It goes even deeper to attach to the distal phalange. Now, extensor indices. So indices meaning your index finger. So it extends your index finger at the MCP joint. Now, the innervation is also the deep branch of the radial nerve. Okay, so this is just a quick question. So I'm going to give you guys again 10 seconds. Try to answer this. Okay, so the answer right here is the radial nerve. So for the guys that got this wrong, oh, I'm sorry, it's right here. It's the first muscle, yeah. So the radial nerve innervates supinator muscle. If it hypercontracts, or if anything goes wrong with this muscle, the radial nerve gets affected. Okay, we're officially done with the muscles of the forearm. Now we're going to discuss some important points that you guys need to know. There's something known as the anatomical snuff box. Now it's only present when you extend your wrist. There's like a prominence or like a depression, sorry, that shows up at the base of your thumb. So why is it called snuff box? Because back in the day, in the 18th century, I guess, people used to take this area to take a pinch of stuff. So they usually put some drugs here and they sniff it. So hence the name snuff box. But trying to make it more respectful, so anatomical snuff box. Now there's a lot of different significances for the anatomical snuff box. Now, I think this is all extra information, but the most important thing for you guys to know is that it's important to palpate the radial artery. Other than that, these different points just suggest that it's really important anatomically for surgeons as a diagnostic tool and for clinical examination. Okay. So again, for the borders of the anatomical box, of the anatomical snuff box, we have three major muscles. We have the extensor pollicis longus, we have the extensor pollicis brevis, and we have the abductor pollicis longus. Now, laterally, the extensor pollicis brevis and the abductor pollicis longus define the lateral border, and the extensor pollicis longus defines the medial border. So, a way I remembered this, I know I told you guys that pollicis does not mean police. That's really sticks in your mind as a policeman. So, I just memorized this like as a case of abduction. So, a baby, brevis, was abducted by the abductor pollicis longus. So the brevis was abducted. So extensor pollicis brevis and abductor pollicis longus abducted from the base of the body. So they're going laterally. And the remaining muscle, the extensor pollicis longus, is on the medial side. So policemen looking for like the drugs in the snuff box. So this is only for memorization purposes. Don't take this literally. So we have the floor of the anatomical snuff box. The floor conveniently at the lateral side, the lateral carpal bones, the scaphoid, and trapedium. So you guys still remember the mnemonic, straight line to pinky. We're building a straight line to the pinky, from the thumb to the pinky. But then here comes the thumb, trapezium. So the two lateral carpal bones make up the floor of the anatomical snuff box. Again, the radial artery passes through the anatomical snuff box. Hence, the pulse is taken sometimes at the anatomical snuff box. So this is actually really important to know. It's actually really high yield. The radial artery passes through the anatomical snuff box. So how do we memorize this? The radial artery is the radial artery, is the artery that supplies the lateral muscles or the lateral compartment. So it's all convenient. All muscles, yeah, if you guys know the basics of the anatomy, plus everything just starts to make sense. Those muscles are all supply the thumb. It makes sense that all the lateral muscles would make up the border, the borders of the anatomical snuff box. The carpal bones are on the lateral surface. The radial artery is on the lateral surface. And finally, the radial nerve and your cephalic vein. All of them sit laterally. خلاص, if you guys know the basics of where each structure started, you guys could just easily know this without even memorizing it. It just comes to your mind automatically. At the beginning of the lecture, I mentioned to you guys in the orientation that you have two veins. You have the cephalic and the basilic vein. The basilic, close to the base, it's the medial vein. The cephalic, the letter C comes after B, sits on the lateral side. خلاص, the snuff box is on your thumb side. It's on the lateral side. Therefore, the cephalic vein. Additionally, the radial nerve also supplies the lateral side, or sorry, is on the lateral side. So it makes sense that the radial nerve superficially passes the anatomical snuff box. Now, an important condition or clinical scenario here is the golfer's elbow. So the golfer's elbow, also known as medial epicondylitis, is a condition characterized by pain and inflammation of the inner side of the elbow. Now, it's caused by overuse or repetitive strain on the tendons that attach the medial epicondyle of the humerus. So the bony pump or the medial epicondyle of the elbow gets inflamed, basically. Now, it does not only occur in people who play golf, although it's really common in people who do play golf, but it does not only occur in people that play golf. Now, a way I used to memorize the golfer's elbow, whether it occurs on the medial or lateral side, because we have another thing called the tennis elbow. So golfer's elbow, I just imagine the guy playing golf. You usually keep the club close to your body, or make it close to your body. خلاص. Since it's close to the base of the body, again, medial side. So if the medial epicondyle is affected. Now, the second one is the tennis elbow. So it's really similar to the golfer's elbow, although it happens on the lateral epicondyle. It's common. It's characterized by pain and tenderness on the outer side or the lateral side of the elbow. It occurs due to repetitive overuse of the forearm muscles and tendons, and particularly those responsible for the wrist extension and gripping activities, which makes sense since the lateral epicondyle is also the common extensor origin. So it makes sense that muscles responsible for wrist extension and gripping activities would get affected. Now, again, despite the name, tennis elbow does not only occur in people that play tennis. It is common in people that play tennis. It's not specific for people that play tennis. It can happen in literally anyone. A way I used to memorize this is that the lateral epicondyle, or when you play tennis, you're swinging the racket away from your body, or like it's pretty distant from your body. So خلاص, the racket is away. So we're talking about something that's away from the body, the lateral epicondyle, not the medial epicondyle. So golfer's elbow, close proximity of the club, medial epicondyle is affected. Tennis elbow, racket is far away from the body, the lateral epicondyle is affected. Okay, we discussed this. We're just re-emphasizing on this point. The pronator syndrome. So we have two heads for the pronator teres. You guys remember the pro boxer with the two heads? The median nerve passes through it. If anything goes wrong with the muscle, or if the muscle hypercontracts, it compresses on the median nerve, resulting in damage to that nerve and the muscle supplied by that nerve. Now, compartment syndrome. Compartment syndrome is actually just a medical condition characterized by increased pressure within a closed muscle compartment from its name. So, compartment syndrome, something that's characterized by pressure within a closed muscle compartment. So this leads to decreased blood flow to the tissues within the compartment. The pressure buildup can impede the delivery of oxygen and nutrients to the muscles and nerves, resulting in tissue damage and potentially permanent disability if left untreated. Now, some key points about compartment syndrome. There are a lot of different causes. It could be caused by trauma, like fractures, crush injuries, severe contusions, that result in swelling within the muscle compartment. So basically anything that increases pressure within the muscular compartment. It can also occur in non-traumatic cases, such as prolonged compression like tight bandages or casts, vascular injuries, or even burns. So we're taking the example of putting on a cast. So let's say someone went to broke their hand and they now put on a cast. The nurse might actually put it on too tight, resulting in a pressure buildup in that compartment, which needs to be relieved by something called an intra-compartment needle. Now, some of the symptoms of compartment syndrome are severe pain, since the nerves are getting compressed by the high pressure buildup, swelling, tightness, numbness, or tingling. All the numbness, tingling are all symptoms of nerve compression. They're all pretty much, all symptoms of nerve compression due to the high pressure buildup. Also results in changes in skin color or temperature, since when there's high pressure buildup, the arteries do not, the flow in the arteries does not reach the muscle efficiently, which is why the muscle starts to losing its skin color. The forearm starts to appear pale. Okay, so this is just to make the explanation a little bit easier. So in the normal state, you guys have the artery supplying the muscle with the O2. So the muscle is happy here. The venous blood gets taken out by the veins. This is in normal state. Now in compartment syndrome, we start right here. The artery wants to supply the muscle, but then the vein wants to take the blood away. Although due to the cast, the high pressure of the cast, the vein cannot overcome the pressure that is presented by the cast, which starts to result in the blood backflowing. Now the pressure keeps building up, until it keeps going back to the muscle, then to the artery, to a level that the artery cannot supply the muscle anymore. So the pressure is really high, keeps on backflowing. The blood starts to accumulate, stasis of the blood, which results in the huge swelling that is present right here. Okay, so flexor synovial sheaths. This is actually really easy, but it's an important concept. So you need the tendons of the muscle. The muscles usually have like a small covering, something that lubricates the tendons, something that protects, something that sticks the tendons to the bone, which is called the flexor synovial sheath. So the blue structure is the flexor synovial sheath. Now we need something that attaches the actual sheath and the tendon to the bone, which are called fibrous digital sheaths. So fibrous bands, digital on your finger, digital meaning finger, and sheath like a covering. We have two different types of fibrous digital sheaths. We have the cruciform and we have the annular sheaths. The cruciform, so from its name, like a crucifix, it's like an X shaped, and the annular just means around. So it's the sheath that goes completely around the sheath. Now, okay. Now, there are two different clinical scenarios here. Or three actually. There's synovitis, there's tendinosynovitis, and there's tenosynovitis. So synovitis, remember we said at the beginning of the lecture, the suffix itis is added to any word or any muscle that's inflamed. So syno, meaning the synovial sheath, gets inflamed, or tendinosynovitis, the tendon, tendonitis, the tendon is inflamed, versus tenosynovitis, which is both when the tendon and the synovial sheath get inflamed together. Okay, so usually people that have this condition are usually pricked by the pricks of a flower, or just a simple infected needle. Like imagine someone just sewing some clothes and they get pricked accidentally by this needle. Most probably it will have some bacteria on it. Now, when the needle pierces the flexor synovial sheath, it gives an entry to the bacteria. It starts to get inflamed, which is the body's natural response to any infection. The inflammation keeps on moving until eventually the tendon gets inflamed, or the needle could just the person could just get pricked directly to the start of the tendon and infect the tendon directly. So it starts as most commonly as synovitis, but then tenosynovitis. Okay, so innervation of the skin. Um, this looks like a really complicated diagram. Well, it's not really complicated. It's really simple. You have the musculocutaneous nerve, which provides sensation to the your lateral side of your forearm. Um, but then we have like the most important or confusing part, at least for the innervations of the skin, is actually the hand innervation. تمام? So I'm going to try to simplify this as much as possible. So at the palmar surface, you have two main nerves. You have three, but two main nerves that are providing cutaneous sensation for this part. We have the ulnar nerve and we have the median nerve. Just give me a minute. Okay, so we have you have the median nerve and we have the ulnar nerve. So just from the shape of the hand, you guys can see like this sort of forms like a U shape. Come on. So U meaning ulnar. It's just a way so you guys can memorize which nerve innervates which part of the hand. Um, this kind of looks like an M. I know it's getting bizarre, but that's the only way. That's like the best way to memorize, guys. So this looks like an M. It's like it's an inverted M. But let's just say that this whole part is innervated by the median nerve. Now it's important to notice that the ring finger it's innervated half and half, half by the median nerve and half by the ulnar nerve. So I just remember this as like the median nerve and the ulnar nerve getting married on the ring finger. So me and you get married on the ring finger. So half is for the ulnar and half is for the median nerve. Now there's a small part of your palm that's actually innervated by the superficial branch of the radial nerve. Now, for the dorsum of the hand or your extensor part, uh, the radial nerve is the major nerve that's responsible for the cutaneous innervation. Although it's not fully for the radial nerve, the tips of your fingers on the dorsum of your hand is still supplied by the median nerve. But again, the half of the top of your finger is supplied by both the median and ulnar nerve. تمام? And your pinky is all supplied by the ulnar nerve. So you guys have you guys have three nerves in each different compartment. You have the median ulnar nerve, radial nerve in the palm, and you have the medial ulnar and radial nerve in your dorsum. Okay, so yeah, this is the last clinically related case. So you have something called the modified Alen test. So يعني, just simplify this. This is a test used by clinicians just to like know the patency of your different arteries, specifically your ulnar and your radial artery. So usually the clinician would just place their fingers on your radial and your ulnar artery. They're occluding the artery for like 5 to 15 seconds. They basically want your hand to go pale. They're gonna ask you to clench your fist so your hand goes pale quicker. So it's when you're performing an action, you need more oxygen supply. So you're actually like kind of draining your wrist, needing more blood supply. So you're just speeding up the process. So going back to the main point, so the clinician usually presses on both of your arteries. Your hand goes pale, similar to the picture right here. But then the clinician takes 1 minute. Then the clinician takes one of their hands off of one of the arteries. Now, usually the artery, if it's healthy, if it's normal, the hand should go back to its original color once one of your fingers is removed off of the patient. So you're just seeing the patency of each individual artery. There's nothing really special here. Just what's important is to know the why this test is used. It's used so you guys can know the patency of the different arteries in your forearm or your wrist. Okay, so we have just last two questions. I'm gonna give you guys 10 questions, 10 seconds to answer each question, and then I'm gonna show you guys the answer. So which nerve innervates the extensor digitorum muscle? So is it A, the posterior interosseous nerve? Is it B, the anterior interosseous nerve? Is it C, the deep branch of the radial nerve? Or is it D, the ulnar nerve? Okay, so the answer here is the posterior interosseous nerve, which is a branch of the radial nerve. So don't get mixed up between the posterior and interosseous branches of the different nerves. The posterior is in the extensor compartment. It's posterior to the interosseous membrane, so it's a branch of the radial nerve. The anterior interosseous nerve is a branch of the median nerve, which supplies the anterior compartment or the flexor compartment of your forearm. Um, the uh, the deep branch of the radial nerve supplies the deep layer of your muscles, and not the superficial layer of your muscles, which is why this answer is wrong. And the ulnar nerve also is responsible for the flexor compartment of your forearm, not your extensor compartment. So this is a pretty simple question. Okay, so which two nerves innervate the flexor digitorum profundus? There's the radial and ulnar nerve, the ulnar and the median nerve, the median and the radial, or the axillary and the radial. So 10 seconds. Okay, so the correct answer right here is the ulnar and the median nerve. So the flexor digitorum profundus is the muscle in your anterior compartment or your flexor compartment of your forearm. We said that flexor digitorum profundus, dos, if you guys remember the mnemonic still, dos meaning it's innervated by two different nerves, your ulnar and your median nerve. Okay, so my references were Dr. Atif's lecture, Dr. Alina's lecture, Can Help and Teach Me Anatomy. Thank you so much for attending, guys. I hope I made the concept a little or slightly easier. I would really appreciate if you guys just scan the code. It's just a survey. I would appreciate if you guys have any comments, any feedback, just write it down on the survey. I also have my email written at the start of the lecture. If you guys have literally anything that you want to ask me, just let me know. Send me an email. Again, thank you guys for attending and have a good rest of your day.